Hello, I'm Dr. Abhishek Mangaonkar, a physician with the Division of Hematology at the Mayo Clinic. I'm joined here by my colleague, Dr. Alejandro Ferrer, a research associate with the Center for Individualized Medicine at the Mayo Clinic. We are here to provide an overview for our upcoming article in the Mayo Clinic Proceedings entitled Clinical Utility and Applicability of a Precision Medicine Approach for Patients with Unexplained Cytopenias. We would like to acknowledge the senior and corresponding author of our article, Dr. Mrinal Patnaik, a consultant and associate professor of medicine with the Division of Hematology and Department of Medicine at the Mayo Clinic. The goal of our study was to offer the latest precision genomics approaches for patients with unexplained cytopenias. We defined unexplained persistent cytopenias as low blood counts in one or more cell lineages that are persistent for 6 months or more, and are unexplained, which means a hematologist has evaluated the patient and ruled out common causes such as nutritional deficiencies, World Health Organization defined myelodysplastic syndrome, effect of drugs and toxins, paroxysmal nocturnal hemoglobinuria, chronic conditions such as hepatitis C, HIV, liver disease, etc. Hence, in order to meet eligibility, a minimum suggested evaluation at the discretion of the referring hematologist included iron chemistries, vitamin B12 levels, methylmalonic acid levels, folate, copper and zinc levels, TSH, liver function tests, infectious serologies, bone marrow aspiration and core biopsy along with cytogenetics, PNH flow cytometry, and abdominal ultrasound to evaluate spleen size. If, after this workup, we could not ascertain a cause for the cytopenias, then these patients were referred and evaluated in our clinic. After a written informed consent, a detailed evaluation was carried out. Samples were collected and stored for research-based tests, and a stepwise precision medicine evaluation was offered to the patients. Precision medicine and precision genomics has expanded our ability to diagnose and manage patients with various hematological disorders, both benign and malignant. Here at the Mayo Clinic, we have a successful ongoing collaboration between the Division of Hematology and the Center for Individualized Medicine. Dr. Ferrer, a research associate from the Center for Individualized Medicine, is here with me today to tell us about the latest precision medicine technologies and illustrate our experience with this clinic.
Thank you, Abhishek. So the ability to take a comprehensive look at the genome of patients has been a powerful tool in clinical research for the last decade. But like with any new technology, it comes with its own challenges. In this paper, we have tried to illustrate our own experience facing these challenges and the decisions that we have taken to overcome them. Most of this is generated from the fact that precision medicine is one good example of research and clinical practice working together. One of the first issues that we found was the high variability of gene panels available in the market that did not really cover 100% of the diseases that we were trying to assess in this clinic. At the same time, most of these panels were very limited, and due to the fast evolving nature of this field, they were sometimes outdated. For this reason, we decided to develop our own CLIA-approved test that includes every gene associated with inherited bone marrow failure described in the literature. This test is very flexible and is very easy to add or remove genes of interest if we decide so. We do scan the literature regularly and keep this test up to date. Nevertheless, as anyone working in genetics knows, having a good gene panel is not enough to deliver a good care for this patient. One of the main complications with these testings are those cases presenting variants of uncertain significance, or VUSs for short. VUS designate variants for which we do not have enough information to conclude if they are causing the phenotype or are not related with the patient phenotype. For this reason, it is impossible to reach a diagnosis using this information. However, when this clinic was established, we decided that we will not stop at this point and we will try to find an answer for this patient as well. When we find one of these unclear results or VUSs, me and my team, under the supervision of Dr. Eric Lee, start a process of variant interpretation and validation focused on each case. We start by gathering all the relevant information available on these variants, either in the literature or relevant databases. And we also use several bioinformatics tools that help us make an educated prediction about the pathogenicity of these variants and if they could be related to the patient's phenotype. We then meet in a monthly tumor board to discuss these results. This meeting includes experts with different backgrounds, including physicians, researchers, bioinformaticians, clinical coordinators, lab technicians, etc. And everyone has the chance to provide their own expertise with the interpretation of the variant. This highlights how important it is to approach this new era in medicine with a multidisciplinary effort, because it is impossible for a single person to master all the fields required to take complete advantage of this technology. Once we have all had the chance to contribute our knowledge about the variant, we then make a consensus decision on how to proceed with this case. Sometimes we suggest additional clinical testing like breakage assays or telomere measurement if they have not been performed yet. Or sometimes we offer research options that could help characterize the impact of the variant in the gene function. In some selected cases, or when considered appropriate, we perform other omics testing like whole exome sequencing, RNA-seq, or methylation assays in order to assess other aspects of the genome. In summary, we use any tool available to find the mechanism of the patient's phenotype and help the physician reach the right diagnosis. Now, Dr. Mangaonkar will explain the results that we found with this approach.
Yes. So using this approach as highlighted by my colleague, we evaluated 68 patients from 2016 to 2018. After a genomic interrogation, we were able to classify them into inherited bone marrow failure syndromes, cytopenias without a known clinical syndrome, which included idiopathic cytopenias of undetermined significance, or ICAS, and clonal cytopenias of undetermined significance, or CCAS, and patients who did not fit into the above two categories. A significant family history was found in about 25% of patients, whereas variants in genes were found in 63% patients, 50% of them being pathogenic, while 21% of them being variants of unclear significance, or VUS. Genomic assessment resulted in an objective change in management in 25% patients. The definition of a change in clinical management was derived from a similar study by Dr. Alder and colleagues from Johns Hopkins University, assessing the utility of a telomere length measurement technique known as flowfish. More importantly, our testing was able to successfully provide a diagnosis for a majority of patients and their families. Some examples of objective changes in clinical management include the decision to start or stop a drug, alter the conditioning regimen intensity or donor selection strategy for hematopoietic stem cell transplant. In summary, we demonstrate the clinical utility of a precision medicine approach for patients with unexplained cytopenias. Future directions for our research include expanding access, developing a more streamlined referral system for patients, conducting cost of care and quality of life studies, understanding the biology of clonal evolution in bone marrow failure syndromes using the knowledge of genetic associations, and provide a platform for early intervention clinical trials. We both thank you for your attention and hope you enjoy reading our paper.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.